It Takes Balls is brought to you by our new sponsor, D's Nuts. Yes, you heard that right. If you've never heard of them, check them out at grabdsnuts.com. But warning, these are not your grandparents' peanuts. D's Nuts has really shaken up the nut game. They're gourmet, fun, and packed with flavor. Whether you're a fan of savory flavors like ranch, sriracha, or hot cheddar, spicy like ghost pepper, or if you have a sweet tooth like me, you'll like the banana pudding. D's Nuts has something for everyone. But D's Nuts aren't just about taste, they're about making a difference. For every bag, can, or piece of D's Nuts merch purchased using the coupon code NUTCHECK on grabdsnuts.com, you can save 10%, and another 10% gets donated towards supporting Testicular Cancer Awareness Foundation. So the next time you're craving a snack that's both delicious and meaningful, reach for D's Nuts. Because when it comes to supporting Testicular Cancer Awareness Foundation, it takes balls and it takes D's Nuts. Available at grabdsnuts.com, Amazon, and Walmart locations nationwide. D's Nuts, a delicious, healthy snack in a variety of fun flavors and making a difference one nut at a time. The stories shared on It Takes Balls are unique to the individual sharing. Always speak with your trusted medical provider for treatment options specific to you. Welcome back to It Takes Balls, presented by Testicular Cancer Awareness Foundation. I'm super excited about this episode. Today, I'm joined by Associate Surgeon at Brigham and Women's Hospital, Dana-Farber Cancer Institute, and Harvard University, Dr. Tim Clinton. Dr. Clinton's clinical interests are in the treatment of all genitourinary malignancies with a focus on urothelial carcinoma, I think I said that right, and testicular cancer utilizing both open and robotic approaches. So Dr. Clinton, thank you so much for being here.
Thanks, Stephen. A real pleasure to be here, and very excited with how popular this podcast is growing in the germ cell and testicular cancer community. So a real honor, but thanks so much.
Oh, it means a lot that you would say that. So before we're going to talk about robotic RPLND today, which, is kind of a hot topic. But before we get into that, we just met at the Testicular Cancer Conference, and we want to break some news here. So I'll let you share what might be coming up next October.
Well, I really appreciate it, and thanks to Kim Jones, the founder of TCAF, and to you and all the sponsors. Looks like we're going to be able to do another year of the TCAF conference, the Testicular Cancer Conference. And this coming fall, so this would be fall of 2025, we'll be hosting it here in Boston through all of our affiliations with Harvard University, Dana-Farber, and Brigham and Women's Mass General. And so very excited to have this coming, and a lot of information and dates to come, but we are a go for another year.
Yeah, it's super exciting. And, a lot of these questions today are going to come from our Facebook support group. So, I encourage anybody listening to join that group, where you'll, of course, get information about the conference as it develops. So let's get started with the questions here from the support group and Reddit. The first one I'm going to ask in regard to RPLND is there a big difference for you between traditional, laparoscopic, and robotic procedures?
It is a difference, but it's more of a difference in technique. And I think the thing that I want to really stress today is that at the end of the day, good surgery is more important than the technique. And this is evident more in testicular cancer than probably any other tumor type there is, because the bar is just so high. Overall survival rates are extremely high, and cure rates are extremely high. And so when you're thinking about surgery for testicular cancer, and specifically what we're talking about today, retroperitoneal lymph node dissections, or RPLNDs, you have to make sure that you're meeting that bar. So while the technical challenges are a little bit different doing it robotically versus open, at the end of the day, the surgery needs to mimic the same and be identical to continue to meet those same cure rates with surgery.
Yeah. And, in that question, it was laparoscopic and robotic. Is there a difference between those, or is that one and the same?
Well, that's a big difference, I would say. When minimally invasive RPLNDs were originally being developed, they were with laparoscopic surgery. I mean, I think there's, reports from even 20 plus years ago. In the urologic community, especially, robotic surgery has just exploded and really grown quite a bit. And so I think most folks have found that the ability to utilize wrists with these instruments, with what the robotic approach allows for much finer dissection, harder to reach areas, let's say, behind some of these great vessels. And so I think in this day and age, robotic surgery is probably the main choice for minimally invasive surgery. It would be hard to find someone who's only doing laparoscopic RPLNDs this day.
Gotcha. Okay. And I'm going to ask these questions in the order that they were presented on the group. So, we might get to one and we've already answered it, and we'll try to skip those. But the next is, how long does this surgery take compared to an open RPLND, and does it have less risk factors, and what is the recovery time?
Okay, so a couple of questions in there, but I'll start with the length of surgery, because this is one that my patients ask me quite a bit and comes up. And here at Brigham and Women's and Dana-Farber, we've tried to answer this question ourselves. So actually, last year we put out our open experience, and we've just recently put together our robotic experience to look at length of stay, the length of the surgery, and sort of all those same perioperative outcomes between the two. When it comes to the length of the operation, it is a little bit longer with the robotic technique. This is a little bit of a finer dissection. It's magnified, but I wouldn't say it's excessive. I do caution folks in that if there was a technique, I think the length of the operation doesn't matter so much as long as the dissection is adequate. Again, surgery, adequate surgery being the key here. So you're preserving the appropriate structures, you're being safe, you're getting the patient to the same outcome, then the length doesn't matter as much. But if you're taking 6, 7, 9 hours for a robotic procedure, now we may be starting to cross over to that more detrimental health benefits because of prolonged anesthesia. And so I think there is maybe a time of diminishing return, but if you're keeping it on average similar, then you're doing okay. And so for us, we looked at our open experience, which averages somewhere around 190 minutes for a primary RPLND. Post-chemo RPLND open, we averaged somewhere around 270 minutes. So a little less than, let's say, 5 hours for post-chemo. Now, when we do it robotically, we actually are quicker in the post-chemotherapy setting. Again, these are sort of select cases. But the nerve sparing with the primary RPLND takes us a little bit longer. So when we put it together, we looked at our average time is right about 300 minutes or 5 hours for the primary setting, and then actually quicker for the post-chemo, a little bit closer to about 4.5 hours.
Wow. Yeah. Sometimes I had open RPLND, but people ask me how long was the surgery, and I'm like, I have no idea. I was asleep.
Exactly. The time, we focus on that and we use it as a surrogate for, how quick or how good the operation is. But at the end of the day, if you're getting out all of the lymph nodes and surrounding tissue that are most important, obviously the ones harboring tissue or tumor, and preserving nerves and obviously avoiding any complications, then the time doesn't matter too much as long as it's within reason. And these are big, long operations, regardless if you do it open or robotic.
Yeah.
Go ahead. I think the other question there was it estimated blood loss? Was that the other one?
Recovery times. Oh,
recovery time. Well, now that's the whole reason to do this minimally invasive. And when we look at it, it's honestly, I think it's one of the best uses of the robot from a recovery standpoint. We obviously use robotics, and I use it for kidney cancer, prostate cancer, bladder cancer. And I haven't seen as big of a benefit as I have for RPLND. Our average length of stay in our open series for RPLNDs is right around 4 days. And when we do it robotically, we keep the folks in the hospital for less than 24 hours. So it's a one-night hospital stay. So that has improved things dramatically. And it's honestly, it's a pain control thing, right? The number of incisions is minimal. It's 5 small incisions, each about 1 centimeter in size or 1.5 centimeters in size. And so compared to, your open RPLND, where it's a large sort of splitting of the 6-pack there, it's the pain wise, it's a little bit easier to manage, and just bowel recovery is quicker. On the whole, this also saves you in the prolonged recovery period, right? As an open RPLND, that can take 2 to 3 months to sort of fully recover. In a robotic series, most patients are feeling back to normal after about 2 weeks. And my full recovery time is 1 month.
Gotcha. Yeah, I'm smiling, thinking in my head about you said the six pack thing. I got a six pack of jelly here, and I actually read my post op notes from Dr. Carey, and he said it was like 10% more difficult because of like some fat or something. So,
Yes,
shout out to big boys. You mentioned nerve sparing. So, a lot of the questions that we got were about, the risk of retrograde ejaculation with the robotic.
Yeah, it comes up obviously anytime you're talking about RPLND, and I think those who are thinking critically about undergoing surgery are really worried about it, because when you think about RPLND, aside from getting through the operation, controlling cancer and minimizing complications, the really only sort of long-term complication, not the only one, but the major one is the retrograde ejaculation. I guess I won't talk too much about why or technical details. I think Dr. Carey went through a lot of this in his podcast, but those nerves are surrounding the aorta, and so on both sides. And so that's why they're at risk when you're doing this sort of dissection around the aorta and the inferior vena cava. In my personal experience, and again, I do this both open and robotic because I really look at it as more of a tool than, let's say, my standard of care or my technique. I actually think it's easier for me to see the nerves robotically. Things are all magnified with the use of the robot. And so these microscopic nerves are actually a little bit more readily apparent in distinguishing it between what is a lymphatic channel versus what is a nerve, and between the lymph nodes as well. But it's still a high rate, right? And I'll mostly talk about in the primary setting. Depending on the series you look at, and a lot of this is really based on templates, which is a little bit of a more nuanced discussion. I only perform bilateral templates. I was trained with Joel Scheinfeld at Memorial Sloan Kettering, and I really believe that a full bilateral template with the nerve sparing is the best thing for the patients to maximize oncologic control. But the nerve sparing is easier for me robotically, but it still runs, it can take up to 2 years to recover and can be as high as 15% of men long term. And so that's with nerve sparing. If you look at the Indiana series, some of those retrograde ejaculation rates could be as low as 3%. But that's, again, with some more templated dissections typically.
Yeah. You mentioned that you do both robotic and open. This isn't the next question here, but I'll ask it. How do you choose the approach for each patient?
This is sort of my big concern in just maybe I'll get into it now is just globally, because I don't think that a robotic RPLND is for everybody, and nor is it for every urologic oncologist out there. I think at the end of the day, the robot is truly just a tool. And so my big fear, and the reason I don't even know that I would love to see robotic RPLND ever as a standard of care, is that while there's a lot of robotic surgeons, there's very few surgeons who specialize in only testicular or germ cell tumors, right? Most of those folks are already been on your podcast or are coming through your podcast. So, there's a handful of folks around the country and in the world. But I do worry about the robotic surgeons out there who one-off, once or twice a year do a robotic RPLND. That's probably not adequate surgery, right? They don't know what the open approach is, adequately. And so when they're trying to mimic something robotically, they're probably doing maybe slightly less than what somebody who also does it open does. And so you really want someone who's doing these operations who does RPLNDs day in and day out, regardless of technique. With that being said, I think that there is benefit, obviously, in doing it robotically, but again, only as a tool. So if I have a patient who comes to me, I look at their scans, I look at the patient, I make a decision about whether they're going to be eligible for a robotic procedure or not. And actually, currently in my practice, it's only about 40 to 50% of folks who are even eligible for a robotic RPLND that I would offer it for. So I still do almost predominantly open, but when I can do it robotically and safely and adequately, I think it's really, really reasonable. Now, you mentioned the criteria for it, and this has been long-winded, but for me, I try to mimic a lot of what the inclusion criteria have been for primary tumors. say the SEMS trial or the prime test trial, for example, for seminoma. So I really try to focus on men who have 3 or less nodes, masses that are less than 3 centimeters or around 3 centimeters, and to try and offer it. In the post-chemotherapy setting, I really try to avoid anybody who is obviously at a post-chemo seminoma because of the fibrotic or desmoplastic reaction, or even if they have a predominance of seminoma in their tumor.
Okay. Yeah. I think it's great that you, take those considerations. My only experience with doctors other than being a patient is watching Grey's Anatomy. And I think those doctors on there kind of sometimes can be like aggressively wanting to try new things, even though it's a fake thing and it's just a show. But, it's good to hear that you're taking considerations
right.
and not just being.
Yeah. Your point is well taken in that sometimes, someone goes all in on just one thing and or open or robotic. And I don't think that's wrong. The standard of care, so it's said, is still open. But I don't think that it should ever be just all robotic because, listen, if you do a lot of testicular cancer, you're still going to get those folks who are coming to you with big 20, 30 centimeter masses involving multiple other organs. There will never be a replacement for open RPLND. It's those select cases where robot may minimize the recovery time, maybe even preserve the nerve slightly better in certain circumstances. And in those instances, I think that's where it's safe to do the robotics.
Gotcha. Okay. The next question is kind of a short one and maybe not direct, but it says, what is the recovery rate? So I'm assuming that means like maybe the relapse rate.
Yeah, so recurrence rates, I think, again, the robotic approach replicates the open approach. So I don't see any differences personally in my practice as far as robotics go. And I think a lot of there's been no trials in this space. It's only been small retrospective series from select surgeons in centers around the country, some of whom have pooled their data together, especially in the post-chemotherapy setting. And we haven't seen any oncologic differences. I think it's worth it to say that the 2 highest volume centers in the country, Memorial Sloan Kettering and Indiana University, who only do open RPLNDs, have seen some select cases where there's been, let's say, some unusual or difference recurrence patterns in folks who have undergone robotic RPLNDs at other centers. So, I don't know that there is, let's say, major differences in the recurrence rates. There may be some differences in recurrence patterns. But again, if you're doing adequate surgery and you're doing it appropriately, then I don't think it should be any different than the open approach.
All right. How readily available is the surgery? Is it available at most big hospitals like Johns Hopkins, this person asks?
That person not to single out Johns Hopkins, but I think, and I don't believe they're doing it yet, but there are a couple great surgeons who are down there. But in the United States, there it is certainly a growing percentage of urologic oncologists who are offering robotic RPLNDs. Obviously, as a younger surgeon, I'm sort of coming in and providing this as well. And doing it quite frequently, but I think you're going to see this increasing. So I think it will become more readily available. Right now, I would say it's relatively rare in the U.S. But this is a rare operation. I think Dr. Carey also stressed this in his podcast. But there's less than 10,000 folks a year who are diagnosed in this country with testicular cancer. There's only a smaller percentage of those who ever require an RPLND. And so these surgeries have been already isolated to most academic centers and high volume places. And even a lot of academic centers do less than 5 or 10 of these a year. So of the surgeons who perform a high volume, only a handful of us provide it robotically at the moment.
I'm going to put you on the spot here, and if you don't know the answer, we can cut this out. But do you know any of the doctors that are doing it? That if you're in the East Coast, if somebody's on the West Coast, is there somebody out there? I mean, I think Dr. Perazio does it in Pennsylvania sometimes.
Yeah. I don't know that we keep it, and I don't want to leave anybody out if they're starting to offer it. But I would say that there's a couple centers that have been doing this and doing it for the last 5, 10 years. And I think more importantly, have been putting it out into the literature. So anybody who's offering this really should be capturing their outcomes. And I think Dr. Carey and Dr. Masterson actually put a nice editorial together. I can't remember where I read it now, but really that if you're going to be doing this, we need to make sure that we're capturing the oncologic outcomes, the survivorship, everything that comes with it, to make sure that this is a safe operation that we're offering. And so, the folks who have put out sort of their sorts of series, Jim Porter, who's out in Washington, has really championed this. I think he was involved with a lot of the testicular cancer conference stuff. Phil Perazio has put his series out. Rob Hamilton recently, who's in Toronto, has recently put out his series as well. Scott Egner, I know, has done it for a while, and then there's even been a small series from MD Anderson. So I would say those have been sort of the centers that have started to look at this. But again, these have been small series. We're talking 20 to 40 patients. So it's over the last decade or so.
Gotcha. Okay. This next one is, it's going to be a mouthful for me. It's kind of an anecdote. It's going to test my reading skills. Dr. Clinton was my son's RPLND surgeon, and he's an amazing professional. Can you talk with him about what nerve sparing actually means, and if the surgeon discloses to the patient if they couldn't spare the nerve, or do they just give the blanket, we will give it 2 years and see if retrograde ejaculation stops? Would love if he could discuss the psychological consequences regarding young men's sexual health after the surgery. I personally feel the mental health outcomes are very overlooked when discussing the possible side effects of the surgery with you men who don't have spouses or children yet. I'd love for him to explore this topic and give it more consideration. Yeah,
I think, listen, it's, I love that one of my patients wrote in, or it sounds like maybe they're a family member, but it's obviously a big concern. I think we, briefly touched on it as far as the retrograde ejaculation goes. For me, the nerve sparing is really important in the primary setting when feasible. But I think we have to be very honest about what, where the nerves that have been preserved and more or less how many. And so it is something that I document. And in fact, I take a photo at the end of every operation to document, but it's more for me. So I know how did that resection, how complete did everything look? And then more importantly, how did those nerves look at the completion of the operation? Because this is a really fine dissection. But just because we preserve the nerves doesn't guarantee that the retrograde ejaculation will resolve or return or back to same volumes. So there's varying shades within all this, right? There's full retrograde ejaculation or anejaculation. There's full preservation of ejaculation, and then everything in between where, maybe it's 50% of the volume that you used to get. And so I think you're right. It's an important topic to make sure that it's disclosed. By the time you're discussing it and you're facing an RPLND, I have to say that a lot of men are sort of maybe not totally bothered, but their focus is on the cancer, right? But long term, it does become a much bigger issue. And so the younger you are, without children, without a family, without a partner, it could be a lot more important to you maybe 5-10 years down the road. And so that doesn't go by the wayside. I'm fortunate that we work in a really fantastic health system here. Dana-Farber has an amazing survivorship clinic for young cancer patients under the age of 35. And so we have actually sex therapists, and we also have a men's health expert who also help us with post-operatively when facing with some of these issues and how to help deal with it. And then, long-term, even helping with fertility.
Gotcha. All right. This next one is kind of more of a technical question. How is severe bleeding, like an arterial nick, controlled in a robotic procedure? One of the reasons my doctor brought up when advocating open RPLND was the fact that a surprise bleed can be stopped with a finger and more quickly repaired than robotically. If the nodes to be removed aren't near any major blood vessels, then this is less of a concern. But for cases of tumors encroaching on major vessels, it seems like open would be significantly less risk.
I think that's absolutely true. It is, there's always risk with open or robotic RPLND because of the nature of where these lymph nodes and lymphatic tissue lie, which is surrounding basically the two major blood vessels in your body, which is, well, at least in your abdomen, which is your aorta and inferior vena cava. And so vascular control is a huge consideration for any operation, open or robotic. It's why I limit the robotic approach to smaller masses so I can have access to these vessels above and below, let's say, a mass that's surrounding the aorta or surrounding the vena cava. I have found ways of managing any sort of bleed from either of these vascular structures robotically. I use smaller clamps that I can actually put through an assistant port to let's say clamp the inferior vena cava so I can repair it if there's a hole or an arterial bleed on the aorta. But we're also used to this, right? To do this operation adequately requires us to control the lumbar arteries and veins, which are quite literally arteries and veins coming off the backside of the aorta inferior vena cava. That's the only way to fully mobilize these vessels and to get access to the tissue essentially between the spine and these vessels. And that is the tissue that I see often being left behind, requiring repeat RPLNDs. And so I spend a lot of time utilizing clips, ties, all sorts of things to divide these lumbar vessels. But and the same concept applies when there is, let's say, an accidental bleed or a bleed that you're not expecting. And so I think that we can control it adequately, but there's certainly times when there's much bigger bleeds that could cause serious harm, and the conversion to open may need to happen. I've never seen it in my own practice, but that's also because we're doing select cases. So I would say that if you're having it done robotically, that means that your surgeon probably feels that the resection and your vessels are safe from whatever he or she is about to do.
When you say conversion, do you mean like you're starting with the robotic and then all of a sudden you got to make a decision live to do the big cut?
Yeah, I would say so. Most vascular surgeons are not robotically trained. So if you really have a serious bleed that's going to require a vascular surgeon to come and assist you, that's going to require conversion to open. Again, the conversion rates of series have all been zero. I think there was one in a post chemotherapy series of about 97 patients. So it was just a very unusual situation. And again, if it wasn't safe, I would not offer this sort of technique. But there certainly could be a serious bleed requiring such a conversion. And I actually, just to feel safer, and maybe it's somewhat voodoo, and now we're getting into my own nuances, but I keep an open tray to resect these tumors on the side in case I ever have to convert.
Yeah, it's kind of like carrying an umbrella so it doesn't rain.
Yeah, exactly.
Let's talk about blood loss, because I think Dr. Masterson's presentation at this most recent conference, he talked about the blood loss being insignificant. And I don't remember if that was just for Indiana, but how does the blood loss compare with the robotic against open?
Well, when I look at robotics, there's really, aside from it just being a tool, I think the only two benefits of robotics over the open approach is one, obviously the recovery, the length of stay. There's only two benefits. So one is the recovery or length of stay, and the second is actually the blood loss. When we do this robotically, we blow your belly up with gas, right? So there's some, we call this the pneumoperitoneum. And that tamponades smaller, let's say, small capillaries or veins that may be have previously oozed or bled during the open operation. So it actually allows us to control the bleeding a little bit better. When you look at the average or estimated blood loss from open versus robotic, it is significantly less in robotics. So for when I compare just our series for open versus robotic, our estimated blood loss for robotics is less than 50 cc's. And when we do it open, it's somewhere around 300 to 400 cc's. Does this make a significant difference to your overall post-operative course? Probably not. But less blood loss, I think in many instances is much better. And I think, a lot of these series, and in fact, when we are doing our trial to compare this, the rate of transfusion may actually be a better indicator. We know that the rate of transfusion in an open RPLND can be anywhere between 5 to 10%, but it's a 0% in the robotic. And that's where some of the transfusion reactions and things like there's small but real risks with transfusion, and we try to avoid it, of course.
Very interesting. And I will address what happens in case I can't edit that out. But
Okay.
but yeah, so if you're just listening and you heard us laughing, Dr. Clinton held up two fingers and Zoom thought he was celebrating
Let's see if
something.
they'll do it again.
So
No.
there were balloons on the screen from Zoom. So shout out Zoom, I guess.
Yes.
The next question, another concern is that of unintentional spread of cancerous material. From what I heard with robotic procedures, there have been some reports of cancer cells being spread to odd places around the abdomen, perhaps from the difficult handling of removed material. With an open procedure, it seems easier to directly remove it rather than dragging it across nearby areas.
This is an excellent question, and one that comes up amongst those of us who do it open versus robotic. Because of those few case reports, again, largely seen at Memorial and Indiana, we're talking about a very few patients, but Indiana, for example, reported on 5 patients. I think Memorial had something similar. It was that there was some odd recurrence patterns from what they saw in prior robotic RPLNDs. Now, these were early days of robotics, and maybe at centers that don't do it often. And so it's hard to know exactly whether an adequate surgery was done. And I'd have to dive into some of the details on templates and things like this. But that's where that concern comes from. And it was previously seen in other tumor types too, which has since been disproven or not seen as well. Kidney cancer is one that comes to mind, bladder cancer being another. So with RPLND, I think it's exceptionally important to make sure that if you have masses that are concerning for tumor involvement, the question is exactly right. Those need to be bagged or put into a bag immediately to limit, that if you have a mass, you don't want it just sort of free flowing throughout the belly, potentially seeding other areas. And I think this is going to be really important in seminoma. I'm not sure if you guys have gone into this on the podcast much, but there's growing interest in RPLND for primary seminomas, so stage 2 seminomas or relapse stage 1. Can we start offering surgery? And that's what the SEMS and the Prime Test trials try to address. Prime Test is the only one that allowed for robotic RPLNDs. So in that trial of about 30, I think it was how many? 33 patients, 50% of those patients were done robotically, whereas SEMS was all done open. But we know that these masses with seminoma are really friable or fragile. In fact, Dr. Masterson and I were talking about it at the last testicular cancer conference. And with robotics, because you don't necessarily have as much tactile feedback as you would open, my concern is that someone is going to do a mass that's too big that would, kind of rupture and thereby seed or spread these tumors. So that's where I think the size of the mass is really important. So you don't want to do it too big. And I put almost no pressure when I'm doing a primary seminoma dissection on the masses themselves, because I am so fearful that tumor could fracture or rupture in any sort of way. And then again, I immediately put it into a bag so there's no seeding anywhere else in the body. And thankfully, in our series here, we have not seen any of these odd recurrence patterns or abnormal spread of these tumor cells. So I think by and large, trials and future studies are all going to show that robotics is quite safe from a recurrence standpoint.
When you say put it in a bag, is that inside the body? So it's not interesting.
Yeah, exactly. Yeah. A body inside the bag. Sorry, a bag inside the body. Again, and I do it for kidney cancer and I do it for bladder cancer so that there's no tumor cells being seeded elsewhere. I think it's a little bit different with prostate cancer. Prostate cancer seems to be a tumor that doesn't really seed other organs. And so I still bag those immediately, but a lot of folks don't. They'll sort of put the prostate off to the side while they, reconstruct the bladder and the urethra. But I think for testicular cancer, kidney cancer, these are tumors where it's really important to make sure that the specimen is going into an area where it doesn't seed the rest of the abdominal cavity.
This is kind of a related question, just from an anecdote from a guy who messaged me on Facebook, who had spread after he noted that he was kicked in his testicles. Could something like a kick to the testicles, we know that you don't really biopsy a testicle, but could a kick to a testicle kind of kick off like the seeding, as you say, like to spread up the lymphatic system, or is that totally, not possible?
Well, no, not really. But this is actually not a totally unheard of scenario. In fact, I myself, when I was in training in Dallas, saw, what we thought was just a ruptured testicle from, playing soccer and kicked in the ball there. And ultimately, when the testicle was removed, it did return as cancerous. And so, sometimes I do think if there's already a process going on in the testicle, such as cancer, it may make it a little bit more fragile if there is some trauma to it. In some ways, it's good, right? We've identified the cancer, but it shouldn't increase your risk of spread. Now, it could increase your risk of spread just locally within the scrotum if the testicle is ruptured. And so, there's certain things that we do during the orchiectomy portion of things if the tumor does seem ruptured in any way. To limit spread locally, but it shouldn't cause lymphatic spread into the retroperitoneum.
Gotcha. Okay. The next question from Reddit is, for those considering the robotic RPLND, what should you know when looking for the right surgeon, facility, et cetera? We might have touched on this a little bit, but we'll just get one concise answer.
Yeah, I think this is the consideration that again, most folks are coming to see me and other high volume folks. At the end of the day, you really need to be looking for someone who treats testicular cancer or germ cell tumor often. It's the one-off surgeons that I think should be, just critically evaluated to make sure that this is someone that you're confident in and someone you trust in. Because at the end of the day, there's no replacement for good surgery. So if you're looking for someone to do either robotic or open, I think you need to go to somebody who just does high volumes of this. There's select centers sort of across the United States that can offer this. And then your surgeon will be honest with you if a robotic or an open approach is best. And I think those are the surgeons you're looking for when trying to make a decision.
Great answer. The next one is kind of another long read. Test my reading again. Out of curiosity, I tried to Google how many RPLNDs are done annually. Most of the references were 10 years old, but it said the overwhelming majority of surgeries were done by urologists who performed one per year. It also said 2 to 3 surgeons perform 23 to 50% of RPLNDs during the same time frame. I assume there's more high volume centers now, but I'm curious what the current numbers are for both open and robotic, which I think we've kind of touched on, but
yeah, again, across the United States, the predominance is still open RPLND, and I don't know that will ever change because oftentimes, if you're doing this operation, let's say it's a big concern for post-chemoteratoma, it's a big mass, those will always be done open. I think there'll be a growing number of RPLNDs given the rise of use of RPLND now for primary seminoma, so we actually may see that number go up, which may lead to an increase in the number of robotic RPLNDs. I don't know that there's a good number to how many are done a year. We do know when that study came out years ago, there was basically a select couple of surgeons who were doing nearly half of the operations. That's probably still true that about half of the operations are done at high volume centers like Brigham and Women's or Memorial Sloan Kettering or Indiana or USC. But there's certainly more institutions just doing high volumes. The concern still remains, and it remains in my mind as well, that the other 50% of RPLNDs being done in this country are being done by those who do less than 10 a year. And again, the nuances of this surgery is that the more you do, the better that operation can be done in general. And when you're going to treat a man who's young, who's healthy, and you're going for cure, you want to make sure that operation is as best as it can be. So I don't know. These are things for I think patients to always consider, and I think it's things for us as surgeons need to be honest about with patients to let them know just how many we do and how common of an operation this is in your practice, and whether you feel comfortable with it.
Speaking of comfort, I'm going to kind of make an adjustment to this next question on the fly and add my own spin to it. Do you always operate with the same OR team? And, does that offer you as a surgeon any level of comfort, working with the same team or having to work with somebody new or different?
Yeah, I think everybody does this a little bit differently. For example, Dr. Scheinfeld in New York has had the same team for many years, and I can't speak for the Indiana folks. For us, there is certain portions that are pretty standardized as far as who is getting all of my operation and everything else together. But I have, by and large, made the robotic operation somewhat independent of who else is in the room and or bedsiding, if that makes sense, because you do need somebody who's at the bedside next to the robot, changing instruments, possibly doing suctioning or passing needles in and out, things like this. But for me, I am very worried about whoever might be bedsiding, even with the same team that I usually use. Because this is around such critical structures, I want to make sure that I control everything. So I actually suction for myself during the operation. I do a lot of single port robotics, and I have something known as the Rosie, which is a continuous sucker that I can utilize. And then I place all the clips, for example, on the aorta myself with a robotic clip applier. So there's certain things that I have modified as opposed to some of my other robotic operations, such that I am in full control of essentially everything that's going in and out of the body. And so in doing so, it actually has sort of lessened the need for, sort of the same team every time. I still largely have the same team essentially every time because it is somewhat of a specialized operation, and we do try to maximize efficiency. But I have made certain adjustments to actually make it, in my mind, safer, or maybe it's my own concerns about just being in control of everything.
Very interesting. All right. I'm out of questions from listeners, but I'll freestyle some. So, Dr. Carey talked about Kylos societies, which sounds like a Jedi or something. What is the risk of that with robotic?
This is a real risk with open and robotic surgery, and especially the more complete of a dissection you do, and maybe the bigger the template too. It is. There's actually, just so you know, there are some concerns that there are higher rates of Kylos ascites in robotic RPLNDs. So the series that have been put out have shown that the rates have actually been higher than a lot of open series. Here we found it to be about the same. So it still runs at about 12% of patients in our robotic series. So it's not zero, but that includes post-chemo and primary RPLNDs. If you were to look at the Indiana series, the rate of Kylos ascites in the open series in primary RPLND, so no chemo, is only about 2 to 3%. So that is quite a bit lower. But again, if you sort of take all comers, for us, it's about 12%. Kylos ascites, though, is somewhat manageable. My own practice, I keep everybody on a low-fat or almost no-fat diet for 2 weeks just to minimize that fluid buildup. If you are that 12% of folks who develop a leak or a buildup of the fluid, a paracentesis is usually required to drain that fluid. Very rarely do you need more than that, but that's typically how it's managed for these leaks.
Interesting. Okay. We've talked a lot about studies. With the robotic, if there's a candidate from, Mississippi and they're listening to this and they want you to do their surgery, like, is there an opportunity for them to travel to Boston to have you do it and be part of a study? Or is like the data from the surgery used after the fact? Like, how does that work? Does that make sense?
Yeah, no, that's a great question. And to be honest, in Boston here, I actually do get a lot of sort of national and international travel, if you will. I think there's enough sort of high volume centers across the United States that sort of regionally, a lot of folks will travel to sort of their, or have been already directed to a center of high volume. But Dana-Farber is such an organization that does a lot of outreach and in Saudi Arabia and in Europe, and so we do get a lot of sort of international travel for some of our patients. And we treat everybody the same, and we can absolutely do the operation here locally. As far as enrollment into our current trial, so we are starting to, and I guess this is going to be our plug, but we're starting to build a trial here to address the question of whether open and robotics are equivalent. It's been a big question for our group. It's been a big question for me. Now that I feel that we've shown adequately in retrospective data that it's safe, it's doable, now we should do it in a randomized trial fashion. That does require certain amounts of follow-up and surveillance. Some of that can be done locally, so any amount of travel can accommodate that.
Gotcha. Okay. And then, you mentioned you don't see robotic ever becoming the standard of care, but, just for the layperson who's listening, when you're doing these trials and studies, what's the process of presenting this and kind of getting it accepted among all urologic oncologists and surgeons?
Yeah, the community. Yeah, and there still is quite a bit of hesitation about the adoption of it. And I have my own hesitation about promoting robotic RPLND or trying to build it into the guidelines in any way, because I want to ensure that those who are doing robotic RPLNDs are also able to do it open. Because again, I think it's more of, do you understand the tumor type? Are you somewhat amount of an oncologist? And do you understand what an open RPLND entails before you start offering robotic RPLNDs? So anyway, I think there's a lot of hesitation on all fronts. But I think we'll start to see an increase of adoption of this technique, this tool, if you will. And the trials and studies will start to build the evidence that it is safe, that it is adequate, and more importantly, that it is equivalent to doing open operations for similar type patients. And if that can be shown, then it can be adopted into the guidelines. So I think you will see it become, let's say, an option as far as robotics versus open. But it never will it replace open RPLND is probably the way I would phrase it.
Who is kind of the keeper of the guidelines? Is that AUA or is it someone above them? Or
well, it depends on which guideline you go by. Essentially, every country or urologic body does govern their own guidelines. So, for example, in urology, it would be the AUA or the American Urologic Association. They do have a testicular cancer guideline. Nationally, for oncologists and urologists and radiation oncologists, there's the NCCN. So they have their own sets of guidelines. And then even in Europe, there's the EAU guidelines. So there's a number of guidelines. There's different folks who sit on different guidelines. So I think the adoption of certain portions of this will slowly make their ways as the evidence becomes stronger. But again, I do help contribute to the NCCN in our group here as far as our recommendations, and we have been hesitant to fully endorse robotic RPLND within national guidelines, again, because of the concerns about just sort of rapid adoption without ensuring that it's sort of experts in the field.
Yeah, that sounds great. Speaking of Europe, some of the questions I know were asked by a patient who lives in, I think, Greece or somewhere. Are there surgeons that you know of in Europe who are, phenomenal at open or robotic or both?
There are a number of centers over there who do high volumes of RPLNDs. I mean, in sort of the Scandinavian countries, for example, and Spain, there's a lot of folks. There's no one in particular that I would single out, but what I will say is that the technique in Europe has been slightly different than the technique that I'm talking about today. So maybe it's a good time to talk about that, which is that a lot of robotic RPLNDs have been done in more of a templated approach. So they're isolating on a resection of the mass and surrounding lymphatic tissue in an isolated area of the retroperitoneum instead of fully across the inferior vena cava and the aorta, which is the full bilateral template. Europe and Spain, for example, have really sort of focused in on sort of just the mass excision, which is just the removal of the lymph node, and not necessarily all of the lymphatic tissue. I do have some concerns with that in that we know that there can be 10 to 15% of nodes that are outside of the quote unquote template. And so I do worry that maybe it's not a complete enough dissection. So I don't know that I would necessarily promote that at the moment unless it can be adequately proven to be safe. So in my scenario, I really do advocate for a full bilateral template, again mimicking what I would do open if I'm going to do it robotic.
Gotcha. Okay. Is there anything else with the robotic that we should talk about that I didn't ask about?
I think we've touched on most everything. It's robotic RPLND is not for everybody. And I do get a lot of patients who are coming in looking for robotic RPLNDs, and I think we have to, as a community, realize that it's a select group of patients where this is a safe and adequate procedure. But that, again, it doesn't replace the need for open RPLND, and that in some patients that is the better route. So while I love the growing numbers of robotic RPLNDs and the number of folks who can do them and offer them, and I think it's a great technique and the recovery is infinitely better, the most important thing is that it is just a tool and a tool to be used just like a certain dissector that you use during an operation to make sure that it's still a safe operation. And so in select patients, it's a great operation, but not for everybody.
I think that's great. And, how much responsibility is on the patient to themselves be educated on their options versus, just going into the doctor's office and you presenting, things as you know them?
Yeah, I really think that, especially for this operation, it's so nuanced. It's already only done by, a handful of folks around the country, on a high volume basis. I think the patients should, and especially if you're listening to this podcast, they probably already know theoretically, what is the dissection, where are we doing this operation? What are some of the potential complications or pitfalls? But at the end of the day, it's really on your surgeon to counsel you on the post-operative recovery, the expectations of long-term retrograde ejaculation, some of the survivorship aspects of it, and then the nuances of open versus robotics. Because I think we need to be honest about it in that there hasn't been a randomized trial. We're going based on retrospective data. While the literature is growing, it's still a relatively new experience for a rare cancer.
I think that's a great place to put a bow on it. Dr. Quinton, where can people find you if they want to reach out or follow you on social media or whatever?
Oh, sure. Yeah. I mean, I'm always happy to answer any questions. I am on Twitter. I think it's just Clinton Tim. But I do try to follow most folks, and through the TCAF, I'm becoming more involved in sort of the, let's say, community on the whole, but always happy to answer any questions that come up.
Great. Thank you so much.
Thanks, Stephen.
For more information and resources for your testicular cancer journey, visit testicularcancerawarenessfoundation.org. You can also follow us on social media at Testis Cancer. We're on Facebook at Testicular Cancer Awareness Foundation.